Next, I am going to call Dr. Meha Kanta. She is going to speak on OCT angiography and emerging diagnostic tool.
Very good afternoon, respected chairperson and delegates. So today I'm going to talk about OCT angiography, which is an emerging diagnostic tool in retinal vascular pathologies. So first, we all know that with the advent of OCT in the year 1996, there was it almost revolutionized our understanding of retinal pathologies and retinal diseases, because we could visualize the layers of the retina, understand the pathogenesis of diseases, and find out where the diseases start from. So even the OCT, it evolved over the years till the year 2006, when we got the spectral domain OCT, which was a very high resolution OCT. You could see all the layers of the retina and the choroid very clearly, and obviously it improved our understanding and prognosticating of diseases. So, but there was one lacuna here. We could see the anatomically, the structures and the diseases, but no vascular pathologies could be seen. Vascular changes could not be appreciated on the OCT. For that, for many decades, we had the dye-based angiography, that is the fluorescein angiography and the ICG, but they also had their limitations. So it was a desire that together the structural morphology and the vascular changes could be seen. So with that desire, basically OCT angio came. People say that you must always be able to predict what's next. And once you know that, then we have the flexibility to evolve. So because we wanted to see them together, then came the emergence of OCTA, which was an OCT angiography. It combined both the features of the OCT and the angiogram, which made the understanding of the disease in totality much more better. So as I said, OCTA is the beginning of a promising future of retinal vascular imaging. The highlights of OCTA is it's non-invasive, you don't need any dye. There's a very accurate visualization of both the retinal and the choroidal vasculature, and most importantly in our practice, it is reproducible and repeatable without any risks. So does that mean that angiography is not required, or FFA and dye-based angiography is now a lost diagnostic tool? No. Angiography, OCTA does not replace FFA and ICG. They have their own advantages, but obviously it is a new tool which has been added, which helps in diagnosis much better. Now, why was dye-based not enough, or it had its shortcomings? It was because it was invasive. We had to give dye. And we all know that the dye had potential for allergic reactions, even life-threatening anaphylaxis. It was time-consuming, and angiography was two-dimensional. It only focused on the superficial retinal circulation. Deep retinal circulation was never very clearly appreciated on FFA. And ICG was focused on choroidal imaging. So together, both the retinal and the choroidal vasculature could not be appreciated on ICG also. So this is an image in which you can see it's a diabetic patient, 47-year-old diabetic patient, and below is also another diabetic patient. What do you see? Let's go on figure A. It's an angiogram where you can see leaking microaneurysms, distorted FAS, few capillary non-perfusion areas. So what happens in an angiogram? Because of the leaking microaneurysms, your FAS is distorted. You cannot really appreciate how distorted is it, or how much is the ischemic area. Also, we have the problem of blocked fluorescence. If you have hemorrhages, then you don't see below that. And B and C are superficial capillary plexus and deep capillary plexus seen on an OCT angiogram. You can see because of the lack of leakage, which does not happen, the FAS is much clearly appreciated. You can quantify it, and therefore you can prognosticate the case much better. Similarly, D also, you can see the angiographic picture and the corresponding OCTA pictures, E and F, of the superficial and the deep capillary plexus, where non-perfusion areas are much better seen because of lack of obscuration of leakage. So, but still, before we go ahead, so that you don't think that it has all the advantages, and the conventional dye angiography does not have advantages compared to OCTA. So I'm highlighting a few points which still the FFA and the ICG do better. Like actual leakage. Just now I said that leakage does not happen, so actually we can see the FAS and the non-perfusion areas better. But sometimes you want to see the leakage. If you're dealing with a CSCR and you want to find the leakage, it's non-responding, then Octa still very clearly does not define that. So we do a conventional angiogram to see the type of leak and where it is. Field. Wider fields are seen by angiogram and ICG. There's still limited field is in Octa. So even the classic 8x8 which we do, you don't see a more than 30 to 45 degree field. Artifacts. We'll come to that later. OCT angiogram has a lot of artifacts. So if you're not trained or well versed with the with its, sometimes you can also read it wrongly. Now there's better visualization of low flow lesions like microaneurysms. To understand it, we'll first go to the principle. One second. Now first we'll come back to how Octa works. Octa basically works on motion contrast detection. That means in simple words, it picks up the RBC flow. What it does, it takes repeated B scans on a single location and it picks up the difference in the blood flow. The difference in the blood flow is rendered into a 3D scan and there you get the OCT angio. So blood flow is very important. The movement of erythrocytes is actually what the OCT angio picks up. So when you have low flow lesions like microaneurysms or lesions in which there is no blood flow, visualization is very poor with Octa because it is highly motion sensitive. Also, like typical OCT, the poor visual acuity and fixation problems sometimes make Octa different. If you have a dense cataract, poor fixation, then angiography is better than doing a Octa. So to understand and interpret for a person, like let's see a simple anterior segment or people who are not doing retina regularly, if you see an Octa image, how do you interpret it? Actually, we see all the 4 retinal vascular layers. The 4 retinal vascular layers are A, the superficial capillary plexus, which is from the internal limiting membrane to the inner plexiform layer. B is the deep retinal vessels, which are from the internal plexiform layer to the outer plexiform layer. C, as you can see, outer retina is avascular. Why? Because we have no blood supply here, so Octa is not going to pick up any images. So C is generally seen as a avascular area. So when you have CNVMs in this area, they are picked up very beautifully because suddenly you see the presence of a membrane where nothing was there because there's no blood flow there. And D is the chorocapillaris, which is 30 to 60 micron below the RP. So in a typical Octa, you'll see all these 4, which will help you identify where the vascular anomaly is in the superficial layer, the deep layer, or towards the outer retina and the chorocapillaris. So I'll just briefly touch upon a few diseases we see in routine and how Octa helps in that. So in diabetes, the role of Octa in diabetes. As I said, you can see microaneurysms here. The arrows point towards the hyperreflective dots. So these are the microaneurysms. But again, I'll mention that they're seen very clearly, but they're not picked up totally because they are low flow lesions. So Octa may not pick up all the microaneurysms, though they are very clearly seen. It helps us to see retinal neovascularization and the plane of neovascularization very clearly. Figure A shows an angiogram where you can see multiple new vessels. Figure B is the Octa image of that, where you can see the CFAN beautiful neovascularization around a capillary non-perfusion area. And the plane, you can correlate it with the plane in the structural OCT. The red area which shows the blood flow clearly shows that it is above the ILM, in the hyaloid, above the ILM around the anterior hyaloid area, which shows the neovascularization. So sometimes in an angiogram it is difficult to distinguish between an IRMA and a neovascularization, a subtle neovascularization. Octa is very good in that because it helps us to see the plane. If the IRMAs are normally at the plane of the retinal vessels, and the neovascularization will be above. It will be above the ILM. So it really helps us to see the plane of neovascularization. Plus one more thing, if it's a very profusely leaking neovascularization, then you don't get to see how big it is and exactly where it's spreading because it's obscured by the dye. But because an Octa does not leak, so the extent and the degree of neovascularization is much better visualized by an OCT angio. The FAS, as we said, is very clearly defined and quantified because of absence of leakage. Now, CNVM and Octa, I think the most important role which OCT angio has is in identification, prognostication, management and follow-up of CNVM because of the outer retinal vasculature is so clearly visualized by the OCT angio. So just a simple picture of a patient with a type 2 CNVM. You can see first look at the OCT, you can see the PED and the underlying membrane. Look at figure A, which is superficial capillary plexus, that's normal. Look at figure B, the deep capillary plexus is okay. Outer retina, which have been avascular, shows a clearly branching membrane This is the neovascular membrane, and we can also be seen the chorocapillaris. So basically, this is a CNVM involving the outer retina and the chorocapillaris, which can be beautifully seen by the octa. So this is just a lot of patterns which we can identify, and a lot of studies are going on as to what are the prognosis of different patterns and how much of treatment may be required looking at the pattern of these CNVMs. Just to see, A is a C-fan pattern, which you can see all the vessels radiating in a single direction. B is a Medusa head pattern, where you see radiating in all directions.
Please conclude. Exceeding time.
Okay.
It is also important. Your presentation, you have to see that you are presenting within time.
Okay, so I'll just conclude.
You can understand you are enjoying your description of the facts.
So.
This is also important. Conclude. Just conclude.
Okay, sir. I'll
All
be.
these are very important for you to learn things.
Okay, I'll just conclude. So that's okay. So basically, CNVM and response to CNVM can be seen very well with an octa because you actually see the lesion. Okay, it's also a very important role in pachychoroid. I'll just show the figure image as a patient with a CNVM with chronic CSR in A, in figure A. In figure B and C, you can see a leaking angiogram. And figure D shows the chronic CSR with some retinal fluid. And if you do an octa, then you beautifully visualize a pachychoroid neovascular membrane, which is the future. So, just to end, it's a very promising and exciting technology, but still we need to explore it much further to understand various pathologies.